record. Okay, well, I'm going to go ahead and just get started with some housekeeping items as everybody is joining us this morning. So to get started, just a couple of housekeeping items. Everybody on here is muted, and so we're going to remain muted through the presentation, and hopefully we'll have some time at the end if anybody has any questions. But if you have any questions during the presentation, please feel free to drop them in the chat box. I will be monitoring the chat throughout the presentation as well to help the speakers. That way, if there's anything that needs to be answered or would like to be answered, we can hopefully get that answered for you towards the end of the presentation. And while you're joining and we're waiting for everybody to kind of hop on, please feel free to share your name and the organization you represent in the chat box so we can see where everybody is from this morning. And I also just want to mention an upcoming seminar that we have next month. So we're actually going to be heading outside as part of our May seminar. We're going to be integrating some time into nature as part of the Sweatland Center's first ecotherapy session, where participants will have the opportunity to connect with and explore beautiful spaces near Case Western Reserve University's campus. So we're actually going to be hiking a short segment of the Doan Brook, which runs right here near campus and is actually really close to the Bioenterprise building, which is where I'm located right now. So we're going to be offering 2 levels of hikes, and one is going to be led by our center's director, Dr. Darcy Friedman, and the other is going to be led by the Center for Community Health Integration's director, Dr. Kurt Stang. So we hope that you will join us for that. We'll be hiking rain or shine, and hopefully it will be, the sun will be shining on May 24th. So we invite you to visit our event page on our website to learn more about this and to register as well. And so speaking of our event page, I'm very excited to share, briefly talk about this real quick, but our link tree for our Sweatland Center. So this is a place where all of our important links are housed. So you can actually find this platform either by scanning this QR code here or by visiting the Linktree website, which I'll be putting in the chat here momentarily. So you can find things like links to our upcoming events, such as that May seminar that I was just speaking about, our news stories, and any opportunities at our center. So we invite you to visit that and bookmark that or save that web page so you can visit it as often as you'd like. Okay, and without further ado, I'm going to introduce our speakers for today's seminar. So I'd like to welcome Dr. Sarah Willen, Dr. Colleen Walsh, and Dr. Abigail Fisher-Williamson. They will be discussing the findings from the Americans' Conceptions of Health Equity Study, or ARCHES is what we refer to it as. And so I'm going to briefly introduce our speakers. Dr. Sarah Willen is an associate professor of anthropology at the University of Connecticut, where she also directs the research program on global health and human rights at the Human Rights Institute. A medical and social-cultural anthropologist, she is the author of the multiple award-winning book, Fighting for Dignity, Migrant Lives at Israel's Margins, an author or editor of 3 books, 6 special issues, and several dozen articles and book chapters on issues of migration and health, health equity, health and human rights, and clinical education, among other topics. She is the principal investigator of ARCHES, co-principal investigator of the NSF-funded study, The Impact of COVID-19 on the Educational and Career Outcomes of First-Generation College Students and Their Families, and co-founder of the Pandemic Journaling Project. Dr. Colleen Walsh is an associate professor in the School of Health Sciences at Cleveland State University. A medical anthropologist focused on urban health, she's interested in using anthropological and political economic models to understand urban living and health inequities. Prior to joining Cleveland State, Dr. Walsh served as adjunct assistant professor in the Department of Anthropology here at Case Western and as a research associate at the Prevention Research Center for Healthy Neighborhoods. She holds a PhD in anthropology from Case Western and is a member of the advisory council for the Sweatland Center. And we welcome Dr. Abigail Fisher-Williamson, who is an associate professor of political science and public policy and law and director of the Center for Hartford Engagement and Research at Trinity College in Hartford, Connecticut. Dr. Williamson serves as the co-principal investigator of ARCHES and is the author of Welcoming New Americans, Local Governments, and Immigrant Incorporation. She holds a PhD and master's in public policy from Harvard and a BA from Williams College. So without further ado, I'm going to stop sharing my screen and I will let our speakers present. Thank you so much for joining us this morning, and we're excited to listen to your presentation.
Wonderful. Thank you so much. So I'm, of the three of us, I am Sarah, and I'm going to get us rolling, and then we're going to take turns presenting different parts of our material this morning. We are so honored to be here. It's really terrific to be able to bring some of this work to this audience, especially after having heard from Colleen so much about the Wetland Center for all these years. So let's go ahead and get rolling, make sure my slides are advancing properly. So what we want to do is give you a bit of an overview of ARCHES, the Americans' Conceptions of Health Equity Study, and talk a little bit about our design and methods, and then give you kind of the greatest hits with a couple of key findings, focusing principally in telegraphic form on our first phase, and we'll explain what that's about. And then we're going to hand things to Abby to share some work that's going to be going out for review from our second phase. After that, and then we'll wrap up with some implications that have been on our minds and that we've been sharing in terms of teaching, research, and also policy. So to get things rolling, we first want to make sure we acknowledge that this research is generously supported by the Robert Wood Johnson Foundation, and this is our grant number. They've been really terrific supports throughout the work. So the design and methods of our study. This is what our website looks like. I think Colleen might be dropping some links in the chat for folks who'd like to learn more. You may recognize this bridge. It's the Detroit Superior Bridge over the Cuyahoga River, which is really indicative of the fact that this work comes out of our really a shared interest that Colleen and I have in Cleveland, and Colleen's deep experience as a researcher interested in issues of health equity and structural racism and its health effects in Cleveland, and also the fact that she and I both happen to be native Clevelanders and CASE alumni. So this is really a project with a heart in Cleveland, which makes it especially exciting to present to you today. Now, the idea for this project comes from some conversations that have been going on in the world of public health for a time now around what we can talk about as the idea of deservingness or health-related deservingness. Sometimes we hear people talk about deservingness in a kind of directive sense, as a kind of automatic binary. Those who are deserving versus those who are not. And we're taking a little bit of a different angle here. We're really opening up the question, how are decisions made about whose health matters? How are decisions made about where to put resources in terms of different populations' health needs and requirements? And we can see that this language of deservingness has been kind of built into how public health talks and thinks for a time. So the image on this slide is from the Robert Wood Johnson Foundation's homepage with a clear assertion that everyone deserves to live the healthiest life possible. And we've seen similar language from a wide range of groups, from the Gates Foundation, Kellogg, APHA, regional health departments, including Cleveland's, and we'll show you an image of that in a moment. And on the other hand, even as we see in public health, this deep assertion that, it's self-evident that everyone deserves what they need to lead a healthy life, this becomes a matter of contestation. So in congressmen and congressional leaders and other politicians often say things like this comment from Mo Brooks from Alabama, suggesting that healthy people should pay less for their health care because of moral choices, because of decisions they've made, because of actions they've taken. Similarly, Mick Mulvaney, who was the head of the OMB under the last presidential administration, made a statement at one point in a presentation at Stanford suggesting that different people deserve more help, more investment, more attention, depending on the kinds of choices they make. So for instance, people who sit at home and eat poorly don't deserve the same kind of attention or investment as people who might make different choices. So, and this is baked into public health logic in Cleveland as well. I think I've lost everyone. So you need to get my attention, please shout. So this is the homepage from a group called HIP-Cuyahoga, which is going to be familiar to many of you, the Health Improvement Partnership-Cuyahoga, which we've partnered with in some of this work. And we see the same language of deservingness. Colleen's going to talk more about HIP-Cuyahoga and how we've worked with them shortly. So we could boil down the core concerns of our work into 3 themes. And I put these, we sometimes talk about them in a slightly more formal way, but I tried to put them in kind of a vernacular language so we can really get at what it is we're interested in. The first is the idea of people's sense of deservingness. And these are, the italicized language here this is questions that we've asked in the work that we've done, and we'll say more in a moment. So how do people think about what we ourselves deserve in the health domain? Whether we have access to what we need to be healthy? And how has that access or lack of access affected both our health and also our views? So that's our first core set of questions around the idea of individuals' sense of deservingness. A second core concern involves the way we think about what others deserve or what different groups deserve. So here a kind of motivating question is, well, when it comes to health, what do different social groups deserve, including my own? And also, how have my own experiences shaped my views on what a group that I might belong to or feel that I belong to deserves, perhaps in contrast to other groups. And then a third core theme in our work is really the question of what catalyzes change? What helps people see differently, to understand connections between structural circumstances and health opportunity, health choices, health outcomes? So the design of our study is in 2 phases. The first phase is a principally qualitative phase, although we have a mixed methods dimension. And it's rooted in Greater Cleveland. So we conducted participant observation with HIP-Cuyahoga, the initiative we mentioned a moment ago. And over an extended period, our team conducted 170 qualitative interviews, semi-structured interviews with a wide range of stakeholders. And we collected demographic data on our interviewees, so we can tell you a bit about them in a moment. And then in the second phase, after an intensive process of analysis, we developed a large series of hypotheses and then chose several hypotheses to test in an online national survey with a sample of over 3,000 people. And we used survey experiments to test some of those hypotheses. We've had a terrific advisory board from folks in Cleveland and beyond, from researchers and community advocates and activists in a wide range of fields and sectors, and it's been a great privilege to work with them and gain their input in developing the project. And to give you a quick sense of what we've done in those semi-structured interviews, which lasted about an hour and 15 minutes each. So they were quite long and intensive, and we covered a wide range of topics. We started by getting to know folks, asking a bit about their personal background. We asked questions about health disparities, awareness of specific health disparities, views on who's responsible for confronting those disparities, and also our interviewees' awareness or acceptance of a social determinants framework. We asked questions about flourishing in health, again, anchored in people's own experience, but moving out into broader circles of the social world. Asking whether people see themselves as flourishing, what's helped or gotten in the way, whether people see themselves as healthy, what's helped, what's gotten in the way. We have asked questions about perspectives on deservingness, questions about whether people feel valued, whether they feel they matter in society, whether they feel that they've gotten their fair share of society's resources. And then we've probed perspectives on views and values in relation to health, race, and fairness, including some specific questions on health equity. And for those who have been involved with HIP-Cuyahoga, we asked about those experiences as well. So I'm going to very quickly give an overview of our sample. We can come back to these slides if you'd like. So we interviewed members of a number of different groups: decision makers, community leaders, public health professionals, clinicians, and also community members. For most groups, about half were involved with HIP-Cuyahoga and about half were not, with one notable exception, and that's our community members who are not involved. And that group is quite large. You can see we interviewed 73 community members who had no involvement with HIP-Cuyahoga, because they're most like the rest of Cleveland, the rest of Cuyahoga County, and by extension, we can begin to generalize about Americans more generally. I'm going to race through this, but roughly that community member sample approximated the demographics of the county in most respects, more or less in terms of income and political affiliation, ideology, and race ethnicity. So just very quickly, in terms of our process of data analysis, I mentioned that we analyzed each interview by producing an analytic memo. We engaged in an intensive process of index coding, so chunking the interviews, and then analytic coding. We worked with the Deduce software program, which we have lots to say about. And we took steps to ensure intercoder reliability as best we could. So that was the first phase, the qualitative phase, based on our interviews in Cleveland. The second phase is our survey phase, led by Abby, again with a nationally representative sample of 3,320 Americans fielded through NORC's AmeriSpeak panel, for those who know about survey research. And the study was in two waves. The first wave was in early to mid-October 2020. And then the second wave followed shortly thereafter, ending just before the presidential election. Let's see. So these dates matter in ways that we can talk about. And the retention rate was quite high across those two waves. So I'm going to introduce one key finding and then hand things over to Colleen. So we'll focus on 5 topics. Several of these are published, several are under review or about to go out for review. First, we're going to talk a little bit about some work we did around equity images. We'll talk a little bit about racial health disparities and whether the causes were clear to our interviewees. We're going to talk a little bit about efforts at what our HIP-Cuyahoga colleagues have talked about in terms of perspective transformation, or having a transformed understanding of the relationship, in particular, in this case, between structural racism and health, what's catalyzed change and the effects of that change. Very quickly, we'll talk about some of our work on critical perspectives on flourishing and health. And then in those first 4 papers all come out of the phase 1 work, and then the Abby will talk about some of our phase 2 findings around health hardship and health-related deservingness. So just very quickly, I would imagine most, if not everyone on this at this event has seen an image like this one. And we wanted to know, do images like this one actually convey the messages that they're supposed to convey? This is sort of the original image that many of us have seen. It's been adapted in a wide variety of ways, essentially trying to convey the difference between equality and equity. Some of these may be familiar to you, some may be new, but they're all really riffing on the same theme. And these all kind of take a similar kind of logic, and then there's another we've encountered. Of course, we've been collecting these. There's one more. There we go. That takes a different approach to trying to convey the differences between equality and equity. And we wanted to know, when people see images like these, are they conveying what they're supposed to convey? And so the paper that we published in Health Education and Behavior digs into what we've learned from our interviewees. And so we showed a version of the image contrasting equality and equity, and we asked our interviewees, have you seen this image or one like it? What's the first thing that comes to mind when you see this image? We also asked a kind of unusual question. When you look at these images, and we showed a version where they were numbered instead of having the 2 sides labeled, we said, which figure best tells your story, if any? And finally, we wanted to clarify for our interviewees, did this image help clarify the distinction between equality and equity? And very quickly, here's what we learned. First of all, these images are in wide circulation, and they're very sticky. They stick in people's minds. So over 60% of our interviewees had seen a version, and that includes people who had no involvement in health, public health, the HIP-Cuyahoga, any such initiative. So they're familiar. Another thing we found was that images like these effectively convey a sense of injustice. So for 74% of those we interviewed, there was a a clear sense that they were conveying a sense that things were not fair, and that there was some sense of injustice happening. But, and this we think is really quite important, we found that these images were much less effective in conveying a need for systems change, a need to, deal with root causes, with fundamental causes, and strikingly, that held for public health professionals and clinicians. And we were quite kind of struck by these findings that even for people we expected might have seen not just a distinction, but also a need for structural change, that wasn't coming through with the frequency we would have anticipated. So we also found some interesting reservations expressed by our interviewees. First, among conservatives, about over a third of conservatives expressed reservations about the moral or the political implications of the image. For instance, suggesting that helping people shouldn't come from, the government, or that responses to a case of unfairness should come from people working harder or individuals rallying together to provide support, as opposed to some kind of systemic intervention. Another reservation that we found quite striking came actually from public health professionals, and fewer expressed this reservation, but we think it's quite important. And their resistance came from a very different place, really suggesting that this is focusing on individuals as opposed to communities, and saying that an individual level focus is the wrong frame, and it may in fact distract from the real work of confronting root causes. So that's the first flash of work, and I'm going to hand things over now to Colleen to talk about our second piece of work.
Okay, great. Thank you so much, Sarah. Can everyone hear me? Okay. Okay. So yeah, I'm going to kind of quickly go through a couple other pieces, one of which is published, one of them is almost ready to be published. So that's this piece on racial disparities. Are the causes of them clear? So we had, as part of our interview, as Sarah said when she talked about the interview topics, we gave our participants 2 examples of local health disparities. Now, we really could have chosen any number of disparities because, as we all know, we have a lot of challenges here. But what we decided to do was choose the overall average 5-year gap in life expectancy between Black residents in our county and white residents. Now, we also know that in places it's much bigger, up to 12 years, 23 years, depending on which numbers you're looking at. But we wanted to ask people about that gap in life expectancy. And then also the disproportionate lead poisoning in predominantly African-American neighborhoods. So they were given these maps where the top one shows elevated blood lead levels among children, and the bottom one shows the darker blue being predominantly higher percentages of African-American community members. So again, we asked, are you aware of the issue? How do you explain this? What do you think causes these things? Do you have any personal experiences with the issue? Which kind of was a way to get people to think about that as something that could be personal if it was. Do you have any response? Who is responsible for addressing this? If anyone, should we be working on these issues? And then what's the role of government depending on how they identified who might be responsible for this. So really, as we were looking at the analysis of this, we were sort of trying to understand the way that Americans or members of our study had this acceptance or awareness of the social determinants of health framework. So overall, now this analysis focuses on that community member sample, as we talked about, and I see a couple questions about our sampling. This one, because we wanted to have the portion of the sample that is most representative of the county, this is what these analysis, because I think, our members of HIP-Cuyahoga and our clinicians and our public health people are going to know about this stuff a lot more. So this analysis is on the community members. So overall, 64% had heard about the gap in life expectancy, meaning they were somewhat aware of it. That just meant they had heard about it. They kind of were familiar with it. That compared to lead exposure, we had 79%. And this 15-point percentage gap was statistically significant. So overall, a lot more people had heard of the lead poisoning issue, which to all of us probably isn't very surprising because there has been a lot of work and a lot of coverage of that issue. Most of these variables didn't matter as much, but tended to be that women, those who were older, higher income, and politically liberal were more likely to have heard about them. But what was interesting is when we look at the previously published research, you often hear that people of color because of sort of a lived experience with disparities, are more likely to know about them. And we didn't necessarily find it was sort of a mixed bag. We didn't see this consistently associated like education either. But in general, 77% of African Americans in the community member sample were aware of the life expectancy gap, higher than the 56% of white members of the community member sample. But on the other hand, 80% of the white participants versus 73% of African Americans were aware of the lead exposure. So it was sort of flipped. So, you know, the gap in life expectancy was much less commonly understood or aware among the white population. So when we just think about, we have lots of ways that we sort of pulled out themes for how people understood this, but the life expectancy, what the takeaway really has been is that life expectancy, the way that people talked about those explanations for it, really was a blend of both structural or the sort of social determinants of health and behavioral explanations. So we see, you know, lifestyle choices and diet, what people choose to eat, whether they exercise and take care of their bodies, but also things like access to the things that they need to be healthy. Whereas lead, you had more consistently structural determinants, usually to the exclusion of any behavioral determinants, which may not be surprising because in and of itself, lead in housing and environments is a structural issue. But what's important is how people talked about it as what in the solutions posed and who was saying what. So when we talk about life expectancy, we did hear a lot of discussion of that personal responsibility across the sample, right? Like that we all have responsibility for our health and our behaviors, but also a blended with those ideas that you have to have access to the things that you need to be healthy. Whereas lead, there was a very, very clear consensus, well, not clear consensus, but the majority of people talked about this role for government, that lead was something that was out of people's control. That was something that really needed to be addressed by structural and political and policy decisions. So when we kind of break it down about who says this, and we have more data on these, but ideological conservatives were much more likely to talk about behavioral determinants than identify the government as having a role in both of these health disparities. And then what was interesting is that we saw that African Americans were just as likely as white conservatives to talk about personal responsibility for health, which is sometimes counterintuitive, but also I think those of us who do work do understand that there is this large sense in the community about taking personal responsibility for our health. So even amongst people who may be facing structural barriers, there's still this sense that it is sort of my fault. And we see a lot of narratives in those studies in our discussions of health with people, that there's sort of this guilt for not being able to take care of yourself. So there was sort of an interesting finding in terms of who says that. So that just gives the graph we talked about. We tried to break it down by those sort of social determinants, and that would be education. Lack of access to healthy food was different than diet, right? We put that in behavioral. Lack of access to healthcare, poverty, sort of those kinds of things were the ones we grouped as more social determinants versus like culture and diet. Culture is loaded, the way that people emically in our study talked about culture, and genetics and biology, which is also problematic. But you see that it breaks down that, but a lot of people are still willing to sort of see the social determinant framework, but it was much more common in the lead exposure disparity. So I get it. Just in general, we're still working on how these findings, and there's many more to pull from them, but what that means is that are there disparities, or are there ways to talk about these things that might increase the recognition of those social determinants of health that policymakers, public health professionals, educators, everybody can use to sort of get people to understand that health can be out of one's control. So we're sort of interested in thinking about what this means. There may be ways to find common ground, like we saw with African American participants with white conservatives. We see them talking about things in the same way. That might be common ground that we can find. And that messaging might be more helpful if it's catered to certain groups. So, you know, we want to know more research on how people understand these causes and how people talk about disparities, in addition to what we have here and have used to build into the survey. But we really want to know what people do, what this means for action, and then how do we address them. So then the next paper that I'll just briefly touch on involves the HIP-Cuyahoga folks, but some of you may have been interviewed. I can't see all the participants on the screen right now, but we called them Health equity stakeholders in the paper. You can go to the next slide. So learning to see racism, perspective transformation among those and among stakeholders in this, that is HIP-Cuyahoga. And so that's that subsample of people who are obviously more highly educated or higher income just by nature of being clinicians and public health professionals and community leaders and decision makers. And so that's what it really kind of stems from HIP-Cuyahoga's very central promise to look at eliminating structural racism and to use perspective transformation, or that change in hearts and minds, to get people to understand the role of racism in health. And we really wanted to talk to people about that and what does that mean and how did they come to seeing racism as a determinant of health. So what we found in this piece was that there were really 4 key catalysts to this perspective transformation that our participants identified. Witnessing the impacts of racism on others, so either in a professional or personal setting, education or training or formal, this could be your formal education, going to public health school or getting an anthropology degree, or it could be these training sessions. At the time, as you'll recall, and it's at Cleveland Neighborhood Progress was leading the way with the REI training, which is now being taken, now Third Space Action Lab has taken over, and that continues. And we heard a lot of participants talk about those in particular as something that helped them have this understanding. And then there's the personal experience of racism. And then much less common, but also really important, was sort of this idea of getting uncomfortable and or seeing other people get uncomfortable during these discussions of racism and health. So we often hear in this work that you have to have the uncomfortable conversations. And we did hear from our participants that those actually were really important for growth and understanding about racism and health. And so then we kind of looked, while we didn't ask people specifically, what does this mean and how did you take this moving forward? We heard in their stories like the effects of having had perspective transformation. So once you have learned something and you do something different because of it, we learned that people had new terms, concepts, or frameworks to understand how to talk about this, to have a shared language, that people were willing to carry the conversation forward in substantive ways. They wanted to work on this. They felt energized and motivated to do something about racism and its impact on health, and that they also found fellow travelers on this journey of perspective transformation, that those were key things to work together. Sometimes this work is so heavy and so daunting and takes so long because it's so slow. And so to hear people's narratives in saying how they used what they've learned to try to continue to do this work was came out of their stories very clearly. And so those varied by race. It's not it's not surprising that lived experience of racism was much more common among Black health equity stakeholders than white. Same, and training was more important, as was the getting uncomfortable was more important for white folks, which is also probably not not surprising, and that new understanding more common among white folks. So you can go on the next slide. So I think in general, we see that these catalytic experiences do vary by race, and that they are possible, and that we might, these trainings can be helpful regardless of your background, because we heard it from across the board, and that we kind of need flexibility in the curriculum and design to think about the best way to have these discussions and what works for people. And so we sort of conclude that paper with those kinds of highlights. And okay. And then I'll turn it back over to Sarah to talk about this latest work on flourishing.
Sure. And I'll be very quick on this. These are quick flashes, but as you can see, that interview guide we designed was really quite robust and allowed us to ask a lot of different questions and then work with different subsegments of our sample in different ways. So for this 4th bit, this is some work that's just come out in a special issue of Social Science and Medicine Mental Health. Really the gist is that you may have heard about or read about some of the work that's happening now and some public conversations happening now around ideas of flourishing and its relationship to health. And much of that work comes out of the tradition of positive psychology, which tends to see individuals as having a very strong level of influence over their circumstances and their well-being. And essentially what we wanted to know, we've been following work on flourishing and had worked on it in other ways and in other contexts, and wanted to know how does this language of flourishing connect with people? Do people find it meaningful in thinking about how they're doing physically, mentally, in that broader, WHO definition of health and well-being more generally. So we asked people, as you saw, would you describe yourself as flourishing? Why or why not? What's helped? What's gotten in the way? And then we asked the same questions about health. And we found some quite interesting things. And one thing that we found won't be a surprise to this audience, but we think it really needs to be said. And it's that when you ask people if they see themselves as flourishing and what's helped or gotten in the way, they're very likely to talk about having a stable source of income. They're very likely to talk about social determinants of health. And again, no light bulbs going off for us here, but the growing body of literature on flourishing and health rooted in positive psychology doesn't pay attention to those issues. There's a real disconnect from a very rapidly growing area of work on flourishing and health, which is getting lots of funding from the Templeton Foundation and other sources, that's really pushing to influence policy on one hand, and then all the work that we do in what we could call the critical public health on the other hand. And so what we're doing in this work is really saying, let's put these in conversation, because we really need a kind of corrective to the work on flourishing that's very likely to lead toward policies that are going to miss the profound influence of structural factors. So on the left is our new paper. On the right is a piece we just published in The Conversation a couple weeks ago. I think Colleen has links that she can share. On one foot, here's what we found when we asked people if they described themselves as flourishing. If you look at that top row, it's very interesting that 65% of those that we interviewed said they would describe themselves as flourishing or leaned in that direction. That's very high relative to the way, to the findings that the positive psychologists are finding, which also range quite widely, suggesting that this is really difficult to measure and that it's not evident that when people ask about flourishing, they're measuring the same thing. So there's some construct issues there. But substantively, we found very interesting to see really significant gaps between people who are earning less than $30,000 a year in household income versus over $100,000. So people without reliable, stable income are much less likely to describe themselves as flourishing in our findings. We also see significant differences between people who self-identify as white and Black, and those are statistically significant. And we also found a difference that I believe, Abby can correct me, is near statistical significance in terms of whether or not people have a bachelor's degree. So this is, important for us to think about it. It's also interesting for us to look at what people talked about when they identified factors influencing their sense of flourishing. So social support, very high, consistent with the work coming out of positive psychology, but stable income, also extraordinarily high. Social determinants of health, extraordinarily high. And then some of the psychological factors that resonate with factors in the positive psychology work appear, but with less frequency. So we really think that this is, it's important to carve out space for folks working on flourishing in this positive psychology tradition to hear some of what we're finding from our mixed methods work that's published in this special issue shown on your screen. So, if we have to boil this down, what might be wrong with a worldwide effort to help people flourish? And I should add, there's one study that just launched last fall that's working with an N of 240,000 in 22 countries. And this is called the Global Flourishing Study. It's led by folks at Harvard T.H. Chan School of Public Health and Baylor University. And that's really the study that we're kind of keeping an eye on, that we expect will begin producing findings pretty rapidly with an eye toward influencing policy. And that's a very large study. It's going to be very powerful. And we think this is kind of the corrective that we want to put out there. First, to suggest that a narrowly psychological approach to flourishing overestimates individuals' control over their well-being and underestimates the role of systemic inequities. And that for those who struggle to meet their basic needs and those of their loved ones, it's going to take a lot more than sort of psychological activities or changes to flourish. It's going to take structural change. So that's what we can share from phase 1, and I'll hand it over to Abby now to talk a little bit about what we're learning from our phase 2 findings.
Thanks, Sarah. Do you want to take a second to address the 3 questions in the chat first?
I cannot see the question, so maybe you'd like to do that.
Well, so let me read them out to you because I think we should probably address them before we move on. So the first question was about how we distinguish community leaders versus community members in the phase 1 work.
Yes, either anyone can. Abby or Colleen, you want to take that?
Yeah, so either the community leaders could be grassroots community organizing leaders, or they could be heads of community organizations, or they could be members of the clergy. So those were different than decision makers, which were heads of businesses, heads of philanthropy, and like legislators or politicians. So it could be the leaders could be grassroots or community-based leaders, but they were different than decision makers, which would be. Does that make sense?
And Rachel asks, were they self-defined in that way? And no, so really the distinction we made was between people who had influence at a neighborhood level, community leaders, people who had influence at a metro-wide level, decision makers, and then, folks in the community living their lives, community members. That was sort of the distinction we made in terms of sampling. And there were 2 related questions. So Darcy asked, how did we assess, this is again about the equity image, how did we assess if the interviewees were conveying a need for systems change, if they saw a need for systems change in the image? And then Rachel asked, is it the intention of those images to apply that systems level change is needed? Aren't they just supposed to sort of show the distinction between equity and equality?
Should I give that a stab quickly? So in terms of the first question, we were, 2 of us are anthropologists, 1 of us is a political scientist. All of us are comfortable with mixed methods research. So we were using interpretive analytic strategies, reading through the transcripts, in some cases remembering to the back to conversations that we'd had as the interviewers. So we used interpretive methods. We weren't measuring something in assessing what people were responding. We were listening to the gist and listening to the nuances to understand whether they were talking about things that fit into our understanding of a need for systems change. And the paper has some more specific examples of that. And then in terms of the second question, quickly.
If that's the intention, or if they just are just showing,
Yeah, so in the paper, we argue, and one could certainly quibble with this, but we make the argument that that is part of what these messages are trying to convey, that they are designed to not only show a difference between a situation that's supposed to be seen as fair and a situation that's supposed to be seen as unfair, but that they are meant to communicate something deeper, something more intensive, something that extends beyond drawing that simple distinction. And, folks might not agree with that, but I think when we look at the degree to which these images have become ubiquitous and we look at the contexts in which they're used, I think we can marshal a good amount of evidence to suggest that the usage of those images is, and I'm thinking using a kind of sociolinguistics analogy. We could think about language and what it means, or we could think about what it's doing in practice, in social situations. I think when we look at what those images are meant to do when they're put into social situations of conversation and education and training, they are pretty consistently meant to convey something bigger than just there's a difference between these 2 ideas. But we can talk about that more, and others might not agree.
Yeah, and I would just add that part of the reason we drew that conclusion is that if you look at the 2 sides of the equality and equity, the move towards equity in each image involves resource distribution, the moving of boxes from one person to another. And so that's part of why we think it conveys this broader, it aims to convey this broader message of structural change. All right, well, I'm going to give a brief overview of one aspect of the phase 2 work, if you can go to the next slide, Sarah. All right, so our aim in this project overall really was to use inductive qualitative work in phase 1 to inform deductive quantitative work in phase 2, to really form hypotheses inductively and then sort of test them on a national survey. And so I'm going to provide one example of that work. The survey consists of 3 survey experiments, but I'm actually going to talk about an association that we found in our interviews and how we saw in the national sample whether that association was borne out more broadly. So in phase 1, we saw a pattern in which experience of health hardship really expanded support for policies that promote health equity. And so we tested this in phase 2. So we looked at whether people responded that they had experienced a personal health hardship, whether they had experienced hardship during the pandemic, and whether that increased support for policies that promote health equity. But more than that, our qualitative work allowed us to consider how hardship shapes attitudes towards health equity, which can sort of point us towards some overlooked mechanisms for how experiences like the pandemic can shape attitudes. So our qualitative analysis suggests that hardship shapes these attitudes in 3 steps. So the first step is awareness or recognition. So experiencing health hardship can make people aware that they're not fully in control of their health. So being healthy doesn't mean that somehow you've been virtuous. Being unhealthy doesn't mean that somehow you've fallen short. And our broader findings suggest that recognizing that people are not fully in control of their health can really powerfully shape their views about what should be done in terms of health policy. Relatedly, experiences of health hardship can make people aware that factors beyond their personal behavior and biological and genetic factors are strong determinants of health. So having an experience with health hardship really seems to increase recognition that social determinants of social determinants of health in ways that converge with the broader scientific consensus about their importance. So that's step 1. The second step is empathy. So people who experience health hardship often extend their understanding that health is not an individual's control to express a more forgiving attitude to others who are experiencing hardship. So deservingness often is about placing conditions on who should get what. And we find that the experience of hardship sort of cultivates an empathetic attitude towards others that's related to broader, more forgiving assessments of who is deserving. And then the third step is connecting these shifts in beliefs to a shift in policy views, to a sense that something needs to be done to promote health equity. Because I'm going to be working with, Sarah, if you can just go back, well, actually you can stay on this slide. So because I'm going to be working with a number of dependent variables, you'll see that I'll continue to have in blue things that talk about sort of this recognition or awareness, step 1. In green, things that talk about empathy and deservingness, and in red, things that talk about policy views. So, we examined the association between how health hardship, including pandemic hardship, is associated with several dependent variables that speak to each step in our proposed mechanism. And you can sort of see those on the last slide. So we had a variable that was measuring recognition of social determinants of health. We had a variable measuring people's attitudes toward who deserves government assistance with healthcare costs. And then we had a couple of measures of policy attitudes, including a semi-behavioral measure of willingness to sign a petition in support of policies that aim to reduce socioeconomic health disparities. And all of the variables are coded so that higher values indicate greater recognition, broader deservingness, and more support for policies that promote health equity. And I should say also that we pre-registered our hypotheses about these dependent variables prior to analyzing our data. So the paper measures hardship in 3 ways. We have a generalized health hardship index, we have a COVID hardship index, and then we have merged in data on county level COVID cases and deaths per capita. And what we find is that the health hardship index and the COVID hardship index have the predicted effects on our dependent variables, but county level COVID cases and deaths per capita do not. So it's really not about sort of geographic exposure to hardship. It's about this personal shift in views as a result of personally experiencing hardship, which goes along with our predictions. So for the sake of time, I'm going to focus in specifically on pandemic hardship. So this is our COVID hardship index. It measured everything from personal experience with the index, household experience with the illness, all the way down to additional caregiving responsibilities or health and mental health problems as a result of the pandemic. And you can see that it's distributed such that about a quarter of Americans were reporting no COVID hardship, another quarter, one hardship, another quarter, two hardships, and then the remaining quarter, three or more hardships, which going forward, that's around one standard deviation above the mean. And we're going to sort of define that as sort of a higher pandemic impact. All right, so having, you can see here the racial disparities that we know occurred during the pandemic in terms of who is reporting three or more pandemic hardships, but you also see a partisan difference. And so it's really important to see if the findings hold up to controlling for partisanship and ideology. We also control for other variables that are past predictors of views on health equity. All right, next slide. So what you see here is that even with the controls, the relationship between pandemic hardship is associated with the three steps in our equation. So it's associated with an increase in recognition of social determinants of health. It's associated with an increase in or a broader view of health deservingness. And it's particularly has high effects on the policy variables that you see at the bottom. So as just one example, moving from reporting 0 to 3 COVID hardships is associated with a 10 percentage point increase in the likelihood of signing the health equity petition. Next slide. And these effects sustained for Republicans, who you see here in the pink as compared to the Democrats in blue. They're obviously more pronounced for the policy variables. In political science these days, so many of our findings come down to polarization. So Democrats say one thing, Republicans say another. And it's really notable here that the effect of COVID hardship appears to be relatively consistent across Democrats and Republicans. So for a Republican, going from 0 to 3 hardships is associated with an increased likelihood of signing the health equity petition of 17 percentage points. And so on the policy variables, you're seeing a pattern in which COVID hardship is contributing to a convergence in policy views, which is, I think, has meaningful policy implications. So in summary, we see that both generalized health hardship beyond the pandemic, as well as COVID hardship, are associated with increases in recognition of social determinants of health, increased empathy, broader deservingness, and support for policies that promote health equity. And this pattern holds for Republicans, especially with respect to policy views. And this has some important implications. We think that messages that reference the pandemic may have the opportunity to increase support for policies that promote health equity, and those who experienced hardship could be mobilized in support of health equity. And I'll stop there and hand it back to Sarah for implications of the broader project.
I think Colleen's going to wrap us up, actually.
I was just messaging you that I felt like you can go to the next slide. I felt like maybe because we have some great questions, maybe we could just have people, we can have a discussion with the time remaining. But for us, those who teach and do research and do policy and think about these things, we do want to think about what our findings have shown us. And we've talked a little bit about some of these things. So understanding the way different groups feel about health disparities, about racism and health, how we cater messages, how we think about ways to advance health equity is going to vary. So that's sort of the things that we're learning. We are learning that there's some consensus that is sometimes not always seen, but our graphics might be needed. We might need to be clearer about what those graphics are meant to be. You can go next slide, Sarah. Yeah, so from our takeaway from our perspective is that there really is so much value in mixed method research. With the survey would not have been as rich and as depth had we not done the interviews in Cleveland and learned so much and developed the hypotheses to understand, and that there's still so much to be done in thinking about Americans' lived experience, all Americans, conservative, like people of color, everybody facing everything that we have so much to learn from those lived experience around health equity and how we want to continue to understand how there are policy successes to move this. So, and as Sarah mentioned, the current work on flourishing and health, which Tim, I see your question on that. And so maybe that's a good point at which to talk about this, but then I also don't want to miss referencing experiences of COVID might in fact enhance support for policies promoting health equity. So we're sort of thinking about what has worked with what we heard from people and what we're finding in terms of the things that people have some shared values on, and how we can talk about these things to do the important work that all of us here want to do. So Sarah, I don't know if you can see Tim's question. Can you see it now?
I will take a look now. Sorry.
Okay.
Wasn't able to see questions while screen sharing, but thank you
You
all.
can read it too as well.
Yeah.
That way, yeah, you don't have to like sift through the chat. So first of all, I wanted to, yeah, and Tim's here too, so maybe he can just ask it, but I just wanted to quickly say thank you so much for your presentation. I think that it was super insightful. I know I learned so much, and I don't want to take away from Tim's time or anyone else who has any questions, so I'll let him go ahead and ask, but I just did want to sneak in a quick thank you.
Thanks.
Thank you.
Yeah, thanks to everybody for organizing and for this great talk and excellent piece in the conversation. So my question's a little pointed in terms of, like, I don't want to sound too leftist, but to what extent do you think the sort of positive psychology and individual level factors focus kind of flows from our excessive corporate influence in our society? Like, just in brief, like, if you can keep the focus on individual level factors, you really get to keep your profitable but largely harmful system. So if I'm going to point the finger at public health or health research, I might say, oh, well, we talk all the time about the ecologic fallacy and never about the individualistic fallacy. But I want to blame corporations right now. So thoughts on either would be greatly appreciated. And thanks for your work.
Maybe I'll take this one. Thank you so much for your question, Tim. I mean, I have a lot of opinions on this, and you can see each of us is sort of coming with a different set of interests and skills to this project. And this is the one that that's been really under my skin for a lot of time. And I would say, if I can find it quickly, I'll show you. Actually, here it is. There's a great book by Daniel Horowitz on the history of positive psychology that's worth a read. It's called Happier ? And it doesn't point a clear finger in the direction of corporations, but it does absolutely point to some of the ways in which there are alignments of certain individualized models of well-being that align with and have garnered support from both enterprising psychologists who get into the public eye and make a name for themselves, and also foundations that have a particular political bent that derive their resources from certain forms of industry. And some of those have big names, and some of them have particular political slants that will be familiar. So there's a good amount of work on Flourishing that's supported by Koch, the Koch brothers. There's a good amount of funding, a really significant amount now that's funded by the Templeton Foundation, which, so this invites us to think critically about philanthropy and the philanthropic world and the ways in which philanthropic resources come into being and their links to the corporate world, and how, we have these links of the corporate world, certain sectors of the philanthropic world, and certain models of well-being that can then be advanced through funding opportunities for researchers by establishing research centers at universities and so on and so forth. So it's worth a read. I can, and there are others who have written about this as well, but I think you're onto something.
Thank you. I have to look that up. Happier. Awesome. Thanks so much.
Thank you.
Thanks, Tim, for your question. I know we're just about at time, so I do want to be respectful. If anybody has to jump off right at 10, we may have time for one more question, or I know on that final slide that all of your contact information was provided in there. So if anybody does at a later time want to follow up with you via email, I'm assuming from that slide, that would be the best way to get in contact. Yes. Great. Thank you so much. Yeah, and happier ? Good to know. I'll have to look into that as well. All right, well, yeah, we're at 10, so then I guess we'll go ahead and call it here, stop it here. But thank you so much again, Colleen and Sarah and Abby, for joining us this morning. We are so thrilled to have you sharing the findings from the study. And just for everyone else's just so you know, there's two things. We are going to be putting all of those links to the resources that Colleen provided earlier in the chat on our link tree. So we'll make an April seminar resources link, and everything will be there, so you can kind of have everything in one place if you're interested in looking into those resources a little bit further. And then the recording to this seminar and the slides will be on our website by the end of the week on the event page. So you will be able to view it at a later time if you want to go back and watch it.
Thank you so much to all of you for inviting us and for all your positive comments. I really enjoyed this. So reach out if you want to discuss anything more. So
great. Thank you so much. Everybody have a great rest of your day and your rest of your week too. Bye.
Bye.
Thank you all.